Okay, so what I'm going to present to you today are some thoughts coming out of a book that Geoffrey mentioned, Phenomenological Bioethics, Medical Technologies, Human Suffering, and the Meaning of Being Alive. And in this book, I tried to show how the traditional phenomenology could be helpful in transforming or at least improving contemporary bioethics in various ways. So I tried to sketch a kind of program, I guess one could say, for how phenomenology should enter bioethics. I mean, this is one proposal. I can see many ways in which phenomenology could be helpful in bioethics, but this is sort of my attempt. And what I'm going to do today is that I'm going to try to explain the attempt, how I set it up. And I'm not going to be able to go through all the themes of the books, of course. I'm going to go on for maybe about 40 minutes or something like that. I will mainly stay in the, let's say, first two chapters, actually. But there are sort of many other themes coming up, as you see in later chapters, that I will only hint at. But I hope I will be able to explain how the whole thing, so to say, hangs together, and how it's possible to sort of proceed to the clinical themes of empathy and hermeneutics, and also to themes concerning new medical technologies involved in the beginning of life and the end of life, as you see sort of projected on the screen now with the chapter overview. So let's see if I can move to next slide. Yes. So the first important question, maybe, if you're sort of making an attempt to do phenomenological bioethics, is to ask the question why we in the first place sort of need phenomenology in bioethics. And this question is coming out of the kind of situation that phenomenology is actually rather absent in contemporary bioethics, which many of you will know. Contemporary bioethics is dominated by moral philosophy in the analytical tradition of philosophy, mainly theories belonging to the liberal tradition of human rights, utilitarianism, and also theories of distributive justice. And the type of applied bioethics that you often see being done out in philosophy departments and medical schools, maybe even more in medical schools, is often set up as a kind of procedure of applying and balancing what is called in the tradition of Beauchamp and Childress prima facie principles. And the four ones being identified as the kind of most important in bioethics are often respecting autonomy, connected to the liberal tradition, of course, doing good and avoiding harm, mainly related to the utilitarian tradition, and also being just, the kind of justice theme. And these principles, which come, as you know, from various moral philosophies in the tradition, are sort of applied to understand and maybe and sometimes also to solve ethical dilemmas. And I think if one is going to sort of answer this question, why do we need phenomenology in addition to this way of doing bioethics? I would say that the traditional analytical approach, in many cases at least, has problems in acknowledging, or sometimes it explicitly denies, that human persons are fundamentally embodied, enworlded, relational, and existentially vulnerable creatures. And this is what I think phenomenology could bring here, a kind of thicker bioethics. And I think also it can do so. I mean, I think phenomenology can do so, and this is sort of my take in the book. It can do so in a way that is compatible with many of the insights of analytical philosophy bioethics, making it thicker, as I said. It's not that we need an entirely new bioethics. We rather need a kind of improved bioethics. But this is certainly sort of a topic for debate, which we can come back to in the discussion. So what is phenomenological bioethics then? Yeah, it's obviously the attempt to make use of philosophical theories in the phenomenological tradition, which you sometimes more broadly refer to as continental philosophy, and bringing in these theories to address and better understand bioethical questions and dilemmas. That is, tricky ethical situation in medicine. I mean, clinical medicine having to do with things happening in the clinical encounter, but also having to do with the development of new medical technologies and the question if they should be sort of used or how they should be used in various situations. And as I said, phenomenology, this tradition of phenomenology in continental philosophy is rather absent in contemporary bioethics, but one could nevertheless say that phenomenology is sort of indirectly present to some extent by work that has not been named phenomenological bioethics, but has been carried out in the tradition of philosophy of medicine and what is often referred to as medical humanities. And I'm thinking here of sort of existing approaches taking on concepts and phenomena such as embodiment, illness, pain, suffering, disability, empathy, dialogue, pregnancy, dying, and so on. And this is, of course, a work that many of us have been busy in before talking about phenomenological bioethics, maybe merely talking about phenomenology of medicine or something like that. And one should also note that empirical qualitative studies have made use of phenomenology as a kind of research method, which you find in medical psychology, sociology, and nursing studies. What you find there are sort of qualitative approaches that have been sort of inspired by the tradition of phenomenology in various ways. And lastly, you also have sort of neighboring traditions in medical ethics to what I here term phenomenological bioethics, namely things such as caring ethics, narrative ethics, virtue ethics, and what is sometimes referred to as biopolitics in the Foucauldian tradition. And all these approaches, I think, sort of at least partly overlap with phenomenological bioethics. So it's not that I'm bringing a totally sort of new thing, but maybe I and a few others are nevertheless bringing a kind of new emphasis in bioethics. So this might be a question that all of you are already familiar with, but I don't know. I was told to address a kind of broader audience. So I think maybe just a couple of minutes on this sort of basic question of what phenomenology is, because I think you could sort of define it in various ways on various levels or as sort of different kinds of activities. And I mean, one sort of basic way to try to define phenomenology is to say that phenomenology is the attempt to give adequate and detailed descriptions of human experiences and situations. And if you talk to doctors or nurses, this is often the kind of understanding they have of phenomenology. It's actually used in this way within sort of medical practice, the phenomenology of a case or something like that. And of course, this is not wrong. This is what phenomenology is. This is a kind of basic sort of characterization that is correct. But I mean, phenomenology is also much more. It is what I've sort of labeled here under two. It's a research program, one can say, in philosophy, starting out with Edmund Husserl that you see here below in the early 20th century, and then including a lot of more or less familiar names. I have listed some of them up here on the screen for the simple reason that they're important to the phenomenological arguments I develop in the book. There are, of course, many others. Lastly, as I hinted at before, phenomenology could also be understood as a qualitative research method that is inspired by this philosophical tradition of phenomenology. I think that's also a legitimate sort of characterization of phenomenology, but it's not what I'm trying to do in the book. I mean, my approach is more directed towards phenomenology understood as number two here above, with a kind of basis, of course, in number one, but it's still the kind of philosophical version of phenomenology, which is this kind of much deeper project that I basically want to bring to bioethics, even though I want to do this in an accessible way. This book that I'm sort of talking about is not meant basically as a book for phenomenologists. I mean, I'm happy if they are interested in reading it, but it's sort of basically directed towards an audience in bioethics and medicine. Okay. Philosophy of medicine then, and also phenomenological philosophy of I mean, ethics, bioethics from a phenomenological standpoint. Maybe it's important to say for those of you who are not sort of familiar with this tradition that I just hinted towards, I think it's sort of essential to say that phenomenology is not some kind of psychological dualism, idealism project attempting to describe and understand the life of the soul or mind or psyche in contrast to the material processes of the body or brain. And the reason I bring this up is that this is a very common misunderstanding of phenomenology that you find amongst analytical philosophers, but also doctors and nurses, I mean, in healthcare. So this is often one of the first things that you have to make clear. The phenomenologist gives privilege to what we call first-person perspective, the first-person perspective in understanding embodied experiences. And in medicine and bioethics, we're obviously very interested in embodied experiences, illness and all the other sort of matters concepts that I talked about before. But I think also, I mean, emphasizing that it is the first person's perspective that is basic to phenomenology, it's important to say that I think the real strength of bringing phenomenology to medicine consists in showing how the first person perspective is sort of systematically related to a second person dialogical perspective of empathy and narrative, and also to a third person scientific perspective investigating and manipulating biological processes of our living bodies. And I think contemporary medicine and bioethics is too often not aware of the difference between and also the interplay of these different perspectives. And I actually think that this matter of how the first person perspective relates to the third person's perspective is very important, not only in medicine and in bioethics, but also to the kind of phenomenological tradition itself, as it has developed the last 20, 30 years, not least in cognitive science and fields like that, where it's been very sort of important to address, well, the brain. And then you get this basic question of what is the most basic perspective, the first person or the third person perspective, and how do they relate to each other? And I think it's important, at least to me, working in this tradition, to say that phenomenology can not just sort of block out the third person perspective. It needs to say something important of how they hang together. And we have Carl Jaspers here down in the corner, famous as psychiatrists, who was one of the first who brought phenomenology to medicine in the field of psychology, in the field of psychiatry. And I mean, just a basic example, I mean, depression. Depression from the first person perspective, depression is, of course, the kind of embodied and worded experiences of the depressed person, the kind of attunements that he or she lives through the world of the depressed person, so to say. That is the first person perspective. The second person perspective, which is very important if we talk about medicine and healthcare, the second person perspective is basically the perspective of the person, the professional, the doctor, the nurse, could also be a friend, of course, attempting to understand what it's like to be depressed. And this is what happens in the clinical encounter. And this is where things like empathy and interpretation are involved in various ways. But nevertheless, the first and second person perspective are fundamentally alike in a sense. I mean, to do phenomenology, you can not just stay with your own experiences, you must sort of get into dialogue with others. So that's not controversial, I mean, from the phenomenological point of view. But in medicine, it's very important. And I think when you talk about phenomenological bioethics, to sort of bring out this difference and the relationship between the first and second person perspective, since this is how clinical medicine happens. But that's not enough. I mean, if you go to the doctor, you expect that he or she not only listens to your story, you also want them to take a look at your body, often with the help of various medical technologies. And this is, of course, where the third person perspective comes in. There is a kind of brain approach to depression also, of course, where you can study the situation or the kind of state of the brain of the depressed person, and you can make different kinds of speculation about what kind of dysfunctions are there presently, or if there are any dysfunctions. I mean, like matters like serotonin or various kind of brain structures. So all these three perspectives are present in medicine and healthcare. And in doing phenomenology of medicine and phenomenological bioethics, you must attempt to sort of bring them together. Most often it's about sort of stressing the first person perspective, of course, since that is what has often been left out in the tradition of modern medicine, being kind of a bit hypnotized by the medical successes and the development of new technology, etc. But nevertheless, in sort of going for the first person perspective and the second person perspective, one should not lose sight of the third person perspective. So this is maybe where it gets interesting, because now I'm getting towards the point when I'm kind of trying to explain my approach to phenomenological bioethics, how I do phenomenological bioethics in this book. And I'm not sort of I'm not sure. I'm pretty sure this is not the only way to do phenomenological bioethics. There are other ways, and I could see at least 3 different ways. And the one that I'm going for in the book is the third one, but I should first mention the 2 first. So I think the first one would simply be to sort of provide rich descriptions of the situations in which these prima facie principles that I talked about before, autonomy, harm, good, just, etc., are being applied. I mean, in sort of ethical dilemmas like having to do with euthanasia, having to do with different forms of patient autonomy, having to do with, there are a number of such sort of standard situations in bioethics. You could just point out as a phenomenologist that the kind of analytical bioethics is too thin, in the sense that it doesn't give justice to the situations that it analyzes. And in order to do this, you must sort of bring in phenomenology. And I think this is basically right. That's what I'm going to do too, that I want to do too. But I don't want to sort of stop there. I also want to sort of relate this kind of descriptive imperative to the philosophical tradition of phenomenology. And I think you could do this in at least 2 different ways. And the first one is not the one that I sort of chosen in the book, but I think it's a perfectly sort of possible one, and maybe it's the most sort of natural or sort of most sort of apparent move. And number 2 then would be to sort of provide a different setup of moral principles, or to make it a bit broader, ethical theories than the ones currently used in contemporary bioethics. And I mean, in this attempt to do bioethics fundamentally differently from the way it's done right now, you could go to sort of, you would have sort of to choose your phenomenologist. I mean, if you choose Scheler, it would be done one way. If you choose Levinas, it would be done in another way. And if you choose Arendt or Foucault, Ricoeur, or any other Jonas, you will end up with a set of at least slightly different forms of phenomenological bioethics. And I think this is possible, and I'm sure it has to a certain extent already been done, but it's not what I do in the book. What I do in the book is instead that I formulate the mission of phenomenological bioethics as the attempt to scrutinize the philosophical anthropology directly or indirectly at hand in analytically philosophy-based bioethics. That is, I ask fundamental questions such as, what does it mean to be a human person, to be a suffering person, to address and understand the suffering person, to investigate and manipulate the bodies of persons. That is the kind of road I've chosen in this book, to go down the kind of track of philosophical anthropology inspired by the phenomenologist. And some of the phenomenologists are more important than others in my book. I had them up on a previous screen, but yeah, okay, I should move on. So I've now sort of presented my sort of basic setup, my strategy in the book, and also how I understand the kind of contemporary situation of bioethics, and how I think phenomenology could sort of move in. What I want to do now is to present what I do in the second chapter of the book, where I try to develop a phenomenology of suffering, which, with the help sort of various resources in the phenomenological tradition, which I think could be helpful in medicine and bioethics. And in developing this concept of suffering, I'm of course involved in addressing things that has to do with the two first principles, to do good, avoid harm. But I also think that sort of autonomy issues, and maybe also to a certain degree at least justice issues, sort of comes in this sort of phenomenological redescription of suffering, because suffering, as the phenomenologists would know, is much more than just it's much more than just being in bodily pain. It's a much broader and sort of deeper concept, and that's what I've tried to show in the book. And in doing this, in trying to develop a phenomenology of suffering, I think it's not only important to say that suffering is something more and sort of more inclusive than just bodily pain. It's also important to point out that there are different types of human suffering. And in the book, I distinguish at least 4 different types: political suffering, bad luck suffering, existential suffering, and illness suffering. And this, I think it's important to make this distinction, because it's not obvious that medicine should sort of help with all types of human suffering. It would be a too sort of demanding project. So you need to sort of investigate the borders of illness suffering, and also see where we're dealing with the kind of suffering that it's maybe not the medics that are sort of the first person to fix. I mean, when it comes to political suffering and bad luck suffering, also existential suffering, it's obvious that it's important to kind of try to relieve or investigate those types of suffering. But illness suffering is surely the kind of primarily terrain, so to say, of medicine, and that's why we have to investigate it if we're going to do phenomenological bioethics. In the case of medicine and healthcare, I think a bodily problem is always present in an experienced way, and this is less obvious in the other cases. And phenomenology, to my mind, is the attempt to understand what particular examples of human suffering consists in. That is, different types, as I talked about, and now I'm also going to address the topic of different levels of suffering, sort of included in various types of suffering. Well, maybe I don't have to read this. It's just a kind of reference to an important work in the philosophy of medicine, Eric Cassell, who has sort of addressed this need for a kind of broader concept of suffering without sort of without addressing phenomenology. I don't think he's very well versed in that tradition, so that is not the kind of resources he brings in. But his message is very helpful for a phenomenologist, because he sort of points out exactly how this concept of suffering needs to be expanded and deepened if it's going to sort of bring justice to human suffering as it's experienced. And I think phenomenology then, as a theory of embodied experience, lived body, is a kind of sort of very well-known phenomenological concept, and also a theory of being in the world, also very primary sort of phenomenological concept coming from Heidegger, but then sort of migrating to nearly not every, but many sort of other phenomenologists like Merleau-Ponty or Sartre. I think such a theory may, as I said, provide a more complete and coherent theory of suffering in bioethics than present alternatives. And I think it could do so by connecting the dimensions of body, the lived body, worldhood, the being in the world, and also what I've chosen to term the self-understanding in the life of a person. So here you have the monk's famous picture, and I brought that as an illustration because it's, well, Munch makes so obvious that the suffering of this poor, screaming, anxious person sort of fills up his or her entire world. This is a very nice, I think, picture of what attunement or mood is really like in the experience perspective. To elaborate a little bit further on this sort of phenomenological sort of basics of phenomenology of suffering, I mean, to be a person would mean to have embodied experiences of things in the world, and this would be done together with other persons. It's important when we talk about being in the world that it's always kind of an intersubjective phenomenon to the phenomenologist. Experiences that we have, not only experiences of illness, but experiences of all things, I would say, are always attuned. This is a Heideggerian concept coming from Befindlichkeit und Stimmung, in the German terms. And this sort of attunement to make mood or attunement a basic concept means that the things in the world that show up to me will always do this on the basis of an attunement. So if you're experiencing anxiety as a figure in Munch's painting, you will sort of not only experience the world differently from, you know, the kind of different example of, for instance, being in love or something like that, or being very happy. It's not just that you will have a different kind of atmosphere to your experience. It's also that different things will show up to you. Or maybe if you're in very intense anxiety, I mean, nothing will show up to you. That's really the way Heidegger, for instance, develops his phenomenology of anxiety in being in time. Nevertheless, I think the lived bodily aspect, which is part of the attunement, it's important to sort of point out here that the bodily aspect means that every experience is basically mine. It's me having the experience. It's me feeling the experiences, and that's something very important. Not least when you're ill, because I mean the others will not feel your headache. It's your headache. But the experiences they attain meaning by being about things that belong to a shared world. And these worldly patterns or meaningfulness, we can call them cultural horizons, they provide the things I perceive and think and do in the world with content and significance in various ways. And these experiences are also temporarily and narratively organized in various ways. I mean, they belong together in power of being past, present, and future parts of my life in the world with others. And here you have Sartre and Ricoeur at the bottom. So in the book, I make a kind of basic proposal for how we should understand suffering, and primarily illness suffering, which is the kind of part of suffering or the concept of suffering that I'm most interested in the book. So my proposal then is that suffering is an alienating mood, an alienated attunement of being in the world, overcoming a person and engaging her in embodied struggles to remain at home in the world in the face of the loss of meaning and purpose in life. And this means that suffering will involve painful experiences at different levels of the person's being in the world. And this is important for me, that there are different levels here. Nevertheless, the levels hang together through this suffering mood, but they are nevertheless distinguishable, the levels, by being primarily about one, my embodiment, two, my engagements in the world together with others, and three, by being about my core life values. I discuss this concept much more in the book. Core life values are basically the values identifying what is dear to me and who I want to be. I take this concept from Charles Taylor. And the core life values will be enacted by what I call my life narrative. So suffering, illness suffering involves at least the first of these levels. It always has a kind of embodied aspect. And well, you have the counterexample of psychiatry, but I would argue that you have the kind of embodied aspect present also there. This is a discussion that we can enter into in the discussion if you want to. If the illness is a little bit more severe, you will also be affected on level 2. I mean, the suffering will sort of alienate my engagements in the world together with others. I will not be able to go to work. Maybe I will not even be able to get out of bed and cook my food, etc., etc. I mean, the everyday life level, the kind of basic actions will be hindered in various ways by the illness suffering. And if we're talking about a very severe illness that is maybe life-threatening or chronic or something like that, we will also have the involvement of and the alienation taking place on level 3. It will sort of affect in various ways who I'm able to be in the eyes of others and in my own self-understanding, and how I'm able to sort of conduct my life as a whole. Yeah. But this will not be the case in every types of illness. If I just get the flu or something like that, or a very mild version of the coronavirus infection, it might only be level 1, but often level 2, and in severe cases also level 3. That is how I understand suffering, and primarily illness suffering here. And as you see at the bottom, I also do make attempts here to discuss differences between various types of suffering. I mean, political suffering, for instance, would not necessarily involve the bodily level, and not also not the existential level. And existential suffering would primarily be about level 3. All right, so illness suffering means to not be at home, to be alienated in and with 1, one's body, 2, one's world, and 3, one's life narrative. And the life narrative is built by way of core life values. And in the book, I make use of the example of Ivan Illich, you know, the famous protagonist of Tolstoy's novel from the 1880s, The Death of Ivan Illich. And I'm certainly not the first one to do that. It's almost a bit boring. I mean, so many people have brought out this well, great novel, and I'm sure that many of you know the plot. It's about a lawyer, kind of careerist, and the 1880s. I think it's St. Petersburg, if I remember correctly. I think they sort of moved between Moscow and St. Petersburg. I think it's St. Petersburg. Nevertheless, he falls ill with some kind of he has some kind of pain in his stomach that gets continually worse. This is not said in the book, but it's obvious that he's suffering from some kind of intestinal cancer, something like that. But the great thing with sort of using this novel to illustrate what illness suffering is of course that Ivan Illich is not only sort of experiencing bodily pain, he's also experienced the kind of disruption of his whole life. I mean, he's not able to continue his job. He's not able to sort of keep up the conversations and the activities together with his friends, etc., etc. But I mean, what is most striking in the book is that what the illness, this kind of illness suffering does to Ivan Illich is that it really gets him to sort of re-evaluate his whole life. He sort of finds out that his whole life has actually been a kind of fake. I mean, the family that he loves, They don't really understand him. They don't really love him. They just see him as a kind of provider of wealth. And he also comes to sort of look down on their life values and ideals, and the kind of ideals of his colleagues too. So it brings a kind of existential crisis. And that's why it's very helpful to use this novel to illustrate these three different levels of illness suffering that I talked about before. And yeah, I have some quotes here from the book. I don't know if I'm gonna read them to you. This is about the bodily pain. This is about his friends, and how it's no longer possible for him to sort of enjoy in their games and parties and conversations, etc. And this is, I mean, famous also in the novel is the way the doctors approach Ivan Illich. I mean, he basically, what he wants to know is, of course, is it something, is it something dangerous? How will it affect my life? Will I die, etc., etc.? But all the doctors, they refuse to answer this question. They just want to sort of discuss various aspects of the kind of bodily state of Ivan Illich, and possible medical conditions with different kind of blah, blah, blah names that he doesn't understand. And they kind of refuse to enter into this discussion about, well, about the phenomenology of illness, what this illness actually means to Ivan Illich, and the way it affects his life. So this is also a reason why it's great to sort of bring in this novel in discussing phenomenological bioethics, because it's such a good illustration of the way you shouldn't be as a kind of healthcare professional, how you shouldn't act, how you shouldn't approach your patients. Yeah. Okay, I'm not going to read the quotes to you. I'm sure some of you have already read the novel, and I mean, it will just get boring. At least I've sort of explained the main points I want to do here. And to sum up, then, I mean, Ivan Illich's suffering should be understood, I think, if you read the book, as a kind of mood involving bodily pains, alienating his everyday being in the world, and also involving various thoughts, emotions about the meaninglessness of his current life. And that tendency, those thoughts, will change the self-understanding he has built by way of core life values during his life, I mean, his previous life. And that is about values identifying who he is and aspires to be in the eyes of others. So human life, especially when facing life-threatening illness, such in the case of Ivan Illich, is vulnerable to moods that displace the person's finitude and fragility. And such moods, such illness moods, anxiety is a main example, expose a kind of basic existential loneliness and negativity central to human life. And such the being towards death, as Kierkegaard and Heidegger called it, it opens up possibilities for a kind of scrutiny and redefinition of core life values. But it's also potentially damaging for a person if making his life too alien to bear. And especially if alienation is also powerful on the bodily and everyday life levels. So yes, illness suffering could be productive. It could make you sort of view your whole life in a new light. But I mean, if it's going to have this productive quality, it's always best if it's also possible to cure the cancer, so to say. So you can come back to a kind of life that, if not totally healthy, so at least livable again. I mean, to Ivan Illich, who really dies a kind of very terrible death. He dies screaming for 2 days or something like that. It's obvious that the medics are much better of fixing pain now than they were in the 1880s. I mean, we might have other problems in medicine today, but when it comes to palliation, it's really much better, and we should be very, very thankful for that. So I think in the case of Ivan Illich, I mean, this existential suffering that he goes through is maybe it's potentially sort of positive for him, making his understanding of his life and his whole world more authentic, to use a kind of Heideggerian concept, but it's also brutal. I mean, it's such an intense and horrible suffering. You must admit that. And to come back to this issue of palliation, then I mean, most cases of severe suffering in end-of-life care, also those involving questions about euthanasia, um, are not about today bodily pains. Actually, we've gotten much better at fixing bodily pains. They're rather about alienation uh, of everyday being in the world, and the self-understanding of a suffering person. And this I find very interesting. I'm currently busy in a project sort of researching end-of-life questions, including ethical dilemmas and problems surrounding euthanasia and physician-assisted suicide. And it's very sort of helpful, I think, to bring in a phenomenological theory of suffering in this context to see what it is that really matters to people towards the end of life, and what may in some situations even want them to sort of ask for a quicker death. Okay, so I'm coming to an end here. I think medicine and bioethics could profit from a phenomenological understanding of suffering in one, better understanding the tuned, experientially integrated, multi-level and multi-type character of suffering. And also two, in better understanding how approaching and intervening on different levels, body with sort of medication, surgery, world, changing the kind of everyday world in various ways of the person, or self-understanding, how all these three levels could be important and interconnected in the mitigating suffering for a person. And this means, of course, that the doctor needs to have a kind of broader spectrum, but it also means that we could make use of a kind of broader team, I think, in medicine and healthcare, bringing in also other professions such as nurses, psychologists, etc., etc. So just to come back to the book, then the entire book, I'm mostly I spent all time here really with chapter 1 and 2. I think other important philosophical anthropological themes for phenomenological bioethics are, for instance, exploring empathy and hermeneutics as path to understand the suffering person, instead of just relying on applied medical science plus a kind of informed consent model that has been a kind of standard approach, I think, in analytical bioethics. It can also be important as a means of exploring human personhood in relation to reification, medicalization, and instrumentalization processes that are present today. That is how medical procedures, science and technology, but also capitalism, market economy could be problematic for us in other ways than sort of directly connected to suffering, rather by being sort of related to how persons are sort of turned into things, to put it very crudely. And just to mention some bioethical species and themes that are dealt with in the book in addition to suffering. I mean, clinical ethics address psychiatric ethics, discussing the difference between psychiatric illness and somatic illness and so things like that, discussing DSM psychiatry. Also enhancement ethics, this difference between health and other sort of improvements that might be possible today and especially in the future through medicine. And the last two chapters address embryo ethics, abortion ethics, and organ transplantation ethics, questions of brain death, palliative care, and euthanasia. So thank you for listening, and these are all the chapters of the book one more time, but I